tissues. Ischemic heart diseases is the disease to the heart which can decrease in oxygen in the tissues, in the myocytes. We can go into its pathophysiology. Its pathophysiology says that coronary artery cannot supply enough blood to the heart in response to the demand due to coronary artery diseases. Within 10 seconds, myocardial cells experience ischemia. We need to understand two terms: the reversible change and irreversible change. The myocyte can withstand the hypoxic condition. Myocardial cells can withstand the hypoxic condition approximately 20 minutes. Before 20 minutes, it's a reversible change, which means the myocardial cell would not die. It's not going to die. But after 20 minutes, there is an irreversible changes occur, which means the myocytes will dead after 20 minutes. Okay, this is just for and remember. And within 10 seconds, myocardial cells experience ischemia. Then it leads to the ischemic cells cannot get enough oxygen or glucose. We know the blood supplies nutrition like glucose addition to oxygen also, and which leads to decrease in the production of ATP. So what happens there? The necrosis of the cells may happen, or there is a decrease the electrical and muscular function will happen. What mean that there is a arrhythmia will occur, or the heart would not pump enough blood to the peripheral region, and if the oxygen level is decreased in the myocardial cells, the aerobic respiration is ceased and the anaerobic metabolism is carried out. You know, the final product of anaerobic respiration is lactic acid production, and it will accumulate in the cells, which eventually lead to fatigue, and this causes the pain. Okay, and this is the balance. When we start, this is the balance. We need a balance between the oxygen demand and also the supplying of the oxygen. The imbalance in the oxygen supply and the demand of the oxygen is lead to coronary artery diseases. Here we can some pictures which includes there is a occlusion. There may be partial occlusion or maybe complete occlusion. But in partial occlusion, which can present some diseases, which can present some syndromes. Ischemic heart disease is a group of syndromes. Actually, it's a group of syndromes usually seen in atherosclerosis. We need to remember that the incidence of both ischemic heart diseases and atherosclerosis is increases with the age, and we have some manifestation of coronary artery disease or ischemic heart diseases, which may be which includes stable angina, unstable variant angina, or Prince metal angina, and the complete occlusion of coronary artery leads to myocardial infraction. So first we can learn little about the stable angina. It occurs at physical exertion or emotional stress. What happens here in physical exertion? We already said in physical exertion, the increase in the demand for the increased oxygen demand for myocytes. There is an increase in the oxygen demand for myocytes, but actually the coronary artery are partially occluded which eventually leads to the anaerobic respiration and leads to accumulation of lactic acid, and eventually leads to there is a pain in chest pain. This pain is not present in the rest, like in unstable angina. Uh, there is a pain, chest pain, only at physical exertion or emotional stress. In emotional stress, the what happens there, the idea is there is an increase in catecholamines. We have special receptors for catecholamines in the heart, which leads to increase in heart rate. So there is an also increasing in the oxygen demand for myocytes occur. Okay, and we already said the ischemic heart diseases are usually seen in atherosclerosis. If there is a plaque, okay, in atherosclerosis, plaque should make greater than 70 percentage stenosis, then only appears the angina. Okay, when but represent, you should understand there is a only reversible injury to myocyte occur. What I'm saying that it represent the stable angina represent with reversible injury to myocytes. It's highly point reversible. The myocytes are not going to dead in this condition, and the presentation with the chest pain that radiates to left arm or jaw, and we know the pain ceases within 20 minutes, which means it's a reversible. The cell can withhold the under the hypoxia, but I already said that if the pain takes more time than 20 minutes, which means the cell is undergoing the irreversible changes. Okay, another presentations are diaphoresis or profuse sweating and shortness of breath or dyspnea. In ECG shows there is a ST segment depression, and it is relieved by rust or nitroglycerin. Here we can see the epicardium, myocardium, and the endocardium. This is our coronary artery. What it happens if there is a plaque occurs here? We know in stable angina there is a plaque, so the blood can move through this plaque, under this plaque, but the vessel is not completely blocked by plaque, and what really happens there, there is a decrease in the blood flow through this vessel occur. Okay, the lumen is narrowed by plaque. Inappropriate vasoconstriction also occur, which leads to this is the endocardium, myocardium, and epicardium. The most susceptible region to ischemic damage is the subendocardial region, which the ischemia in this region is known as subendocardial ischemia. Okay. And next we can talk about the unstable angina. What is that? How can we differentiate unstable angina from stable angina? If the chest pain present at rest, it may be an indicative of unstable angina. And here is the partial or incomplete occlusion due to atherosclerotic plaque with thrombus. There is a additional feature also come here, that is thrombus. Okay, in stable angina there is no thrombus formation, but unstable angina thrombus is formed. How the thrombus is formed in unstable angina? You know, in stable angina the blood flows here to in this direction, and sometimes the plaque may be ruptured. So plaque may be ruptured. Also there is a endothelium also may be ruptured. So exposed subendothelial region, subendothelial region, you can expose the the injury to endothelium leads to exposed subendothelial collagen, and there is an activation of cascade pathway will occur. So there is a thrombus formation will occur. So but if this in this condition the thrombus is only partially is occluded the coronary artery, so we can't say there will be an infarction occur in unstable angina. I'm saying that the point here I already said, the plaque is ruptured, there is a platelet aggregation, thrombus formation, unopposed vasoconstriction. Okay. In ECG, it shows the ST segment depression relieved by, and the unstable angina is relieved by nitroglycerin. And I already said that if the thrombus can form, if the thrombus is continuously formed, and it can maybe block the whole lumen, so there is a high risk for getting myocardial infarction also, we should remember. uh, Once again I want to say here, in ST segment depression, the the heart wall is not completely undergo in ischemic region. Only the in most cases the subendocardial region is susceptible to ischemic damages. Okay, in ST segment depression, subendocardial depression, so subendocardial infarction. Okay, in transmural infarction, there is an ST segmental elevation. Okay, you should understand the difference. Next manifestation of ischemic heart disease is Prince-Metal angina. Prince-Metal angina has another name is known as variant angina. It is due to coronary artery vasospasm. Here, the increasing the vascular spasticity leads to variant angina. It leads to an episodic chest pain unrelated to excitation. Here is the complete, you can see the almost completely occlusion of coronary artery. The vascular spasm clamps down the coronary artery to occlude it. So what happens here is that in ECG there is a ST segment elevation can happen because it is due to the transmural ischemic damage or ischemia. And but we should remember that here is to only the represent with the reversible injury to myocytes. Okay. And the treatment for Prince-Metal angina is nitroglycerin or calcium 2 plus channel blockers. First, I want to say Prince-Metal angina. What happens really is it is happening is coronary spasm, vascular spasm, and completely clamping down the coronary artery leads to the blockage of blood, and there is a transmural, which means the whole myocardium doesn't get any oxygenated blood, so leads to in ECG manifestation is SG segment elevation due to transmural ischemia. It is treatment is nitroglycerin and the calcium 2 plus channel blockers. And also finally we should remember that there is only reversible injury to myocytes, which means the myocytes are not going to death in this condition too. Stable and unstable angina. Here I am saying that just only when the blood is flow through this plate can rupture, it can make thrombus. If this thrombus is only in unstable angina, the thrombus is only partially occluded the coronary artery. Okay, if it block fully, then it may lead to myocardial infarction. Here I say initially I said that subendocardial injury leads to this ST depression, and the transmural or epicardial injury leads to ST elevation. Okay, here is the difference between the subendocardial injury, and here is the transmural injury leads to transmural ischemia. We can talk about the myocardial infarction now. What happens in myocardial infarction? Myocardial infarction, it is a complete occlusion of coronary artery. Complete occlusion of coronary artery is due to the rupture of atherosclerotic plaque with thrombus, which can block the coronary artery, which eventually leads to the necrosis of the cardiomyocytes. What are the other causes of the myocardial infarction, which may be vasospasm, as we already said in Prince metal vasospasm, which can lead to completely clamping down the artery, or emboli. Emboli can get into the coronary artery, which occluded the coronary artery, leads to block the blood to reach the muscular wall. And vasculitis. What is meant by vasculitis? Vasculitis is the inflammation of coronary artery. What happens in inflammation? We know in inflammation there is an endothelial injury will happen. Endothelial injury will lead to the exposing of subendothelial collagen. Subendothelial collagen will lead to activation of cascade of coagulation, which leads to the formation of thrombus, and which occluded completely leads to the myocardial infarction. What are its clinical manifestations of myocardial infarction? Which may crushing severe chest pain. The chest pain is longer than 20 minutes, which means the cell is undergoing irreversible change. The cell is going to die. It is not relieved by nitroglycerin, and also there is a profuse setting for patients, and dyspnea, which means the shortness of breath. What causes the shortness of breath? Because the heart does not pump effectively in this condition, and leads to the pulmonary hypertension, leads to pulmonary edema and dyspnea causes. And usually myocardial infarction involves the left ventricle, and right ventricle and right atria are only spared. Here is we can make an idea here. Here is the right ventricle and the left ventricle. Okay, what happens? These are three arteries here. This is ascending left anterior descending artery here. This one is left anterior descending artery. This is left circumflex artery, and here is the right coronary artery. Okay, these three arteries. What happens? That is left anterior descending artery. When this artery is blocked, most commonly this artery is blocked. What happens in this artery blocks? It can lead to some anterior portion. Here is the anterior portion and the posterior portion of the left ventricle, which leads to the anterior portion, the ischemic, the infarction of anterior portion of the left ventricle, and also some little bit the anterior portion of intraventricular septum. And when the right coronary artery occluded, which can lead to the posterior wall of the left ventricle can get into infraction, and also some posterior region of the interventricular septum can undergo infraction in this condition. And here is the left circumflex artery. When this artery becomes occluded, what happens really, which can lead to the left wall infarction. Okay, what are its treatment? We can now it's going to the treatment. The treatment undergo, we can make a code here: aspirin, aspirin base. I showed the name aspirin as ASM, and B, I put the I after B and ACE, which means there is an inhibitor or blocker. Okay, the first drug is aspirin. What aspirin do here? Aspirin limits the additional thrombus formation. You know, aspirin can decrease the thrombus formation, and supplementary oxygen. So for the additional two here, supplementary oxygen limits the ischemia, and nitrates leads to the helps in the vasodilation of vessels. Here, more useful is venous dilation. Nitrates can dilate both artery and the vein. Here is more useful is venous dilation. Venous dilation, which leads to decreasing the preload, and leads to decrease the stress over heart. And beta blockers slows the heart rate, reduce the risk for arrhythmias, and arrhythmias is a fearful condition occurs within few hours after myocardial infarction. And also ACE inhibitors, angiotensin converting enzyme, it helps to produce the enzyme angiotensin 2, and it has two roles. And first one is the peripheral arteriolar constriction, and second role is absorption of water and electrons. The peripheral arteriolar constriction leads to increase in the afterload, and the absorption of water and sodium leads to hypervolemia. These both conditions are very stressful for or it will increase the left ventricular dilatation. So when we introduce the ACE inhibitors, which can block the or inhibit the stress for the heart, I want to tell some definitive treatment of myocardial infarction. Before that, we need to understand the initial phase of myocardial infarction. In initial phase, we know there is only subendocardial infarction may happen, but the infection may be progressed to transmurally, and the whole muscle wall may undergo infection. So initial phase of the myocardial infarction shows the SG segment depression, and the final stage shows the SG segment elevation. We should understand that subendocardial infection involves less than 50% of myocardial thickness. Okay, you can just hear that this is only less than 50% of the whole myocardial thickness. Okay, how we analyze in laboratory or biochemically this patient is undergoing the myocardial infarction. How we can analyze? There is some cardiac enzymes will produce in these conditions. These enzymes are troponin 1 and CKMB. The troponin 1, before that I want to say the enzyme, how the enzyme is present in the blood in myocardial infarction, because during myocardial infarction cell undergo irreversible change, so which means the cell is going to die, the cell is dead. Okay, the cell is dead, so its membrane become damaged, so the enzymes are present within side of the myocytes, which will go out from the myocytes and leak out from the myocytes to the blood. Okay, the enzyme is and the enzymes are troponin 1 and CKMB. First, I want to say troponin 1. It is the most sensitive and specific marker. So it erases 2 to 4 hours after infarction. The peaks and its concentration reach at maximum at 24 hours, but we should remember that its return to normal is it takes some days, approximately 7 to 10 days it takes to return to its normal. So there is we can't understand, we can't found if there any reinfarction occur within this time period. So we have another enzyme CKMB, also is a cardiac enzyme. It's very helpful for in detecting reinfarction few days after the first myocardial infarction, because it comes to normal level after 72 hours, not like 7 to 10 days in troponin 1. So if there are any myocardial infarction reappear again, CKMB will rise and we can detect. Okay, the CKMB rises 4 to 6 hours after infarction, and it peaks at the 24 hours, like the same in troponin 1. And I want to say that definitive treatment for the myocardial infarction, we heard about the angioplasty, and also we heard about the fibrinolysis treatment. But in angioplasty like procedure, we can open the blocked coronary artery, the oxygenated blood going to myocytes, which is already dead, and it makes two interesting complications. The first one is contraction then necrosis, and second one is reperfusion injuries. What happens really is, when we treat the patient who have myocardial infarction, and which means we open the blocked coronary arteries, but there is some myocytes are already dead, So the oxygen is get into this dead cell, or the blood is reaching to this dead cell, which can form two interesting complications like contraction band necrosis and reperfusion injury. Contraction band necrosis. Which ion is helping for contraction of the heart, which is calcium. Okay. Uh, when the uh, when the calcium, we know in dead cell the membrane is damaged, so the calcium can easily penetrate into the myocyte. So the contraction is done by the proteins, and contraction is happens normally. So this calcium make the myocytes more contracted, and it forms like some bands. Do you understand what I'm saying? In necrotized tissues, the calcium can enter and bind with the protein and lead to contraction of myocyte, and it forms some band lines. Okay, here is a cardiomyocyte. The nucleus is pulled out from the cardiomyocyte, and which is a dead one. And what here we can see here some bands. If you analyze, you can see some bands here. This is contraction band necrosis. The contraction band necrosis, the calcium ions get into the myocytes through the damaged membrane and leads to the contraction of myocyte. Here is a dead myocyte. The nucleus is pulled out, and we can see some bands. These bands are formed by the contraction of myocyte. And next we can study about the reperfusion injury. Reperfusion injury, what it means really. When we open the blocked coronary artery, the blood is going into the dead cell, and there is also with oxygen also get into the myocytes, which is actually a dead one, and it leads to the increased production of free radicals. These free radicals can cause harm to the healthy myocyte, which eventually leads to the injury of the myocyte. So there is an increased cardiac enzymes in these patients after the angioplasty or fibrinolysis.